Hello and welcome to Insight Ophthalmology. I am Dr. Amrit, welcoming you to another lecture on conjunctivitis. Today we are discussing the Phlyctenular Keratoconjunctivitis. So first of all, what exactly is this? So Phlyctenular Keratoconjunctivitis is a non-infectious and we can also call it a nodular inflammatory condition which affects both the conjunctiva and the cornea. Let's discuss the origin of the term. The term basically is derived from the Greek word phlyctena, which means blister. So it basically refers to the appearance of the conjunctival or the corneal nodules, which will ultimately undergo necrosis and leads to ulceration. What is the pathophysiology behind this phlyctenular keratoconjunctivitis? It is basically a delayed type of type 4 hypersensitivity reaction. The T helper 1 cells, they basically secrete the cytokines. These cytokines will then activate the macrophages and the cytotoxic T cells, and this can ultimately cause macrophage accumulation at the site of sensitization. This accumulation of the lymphocytes and macrophages leads to the nodular formation, and those nodules which are formed in the cornea or in the conjunctiva are referred to as phlycten. This basically occurs as a delayed type 4 hypersensitivity reaction to microbial antigens, commonly Mycobacterium tuberculosis or Staphylococcus aureus. So the PKC, that is Phlyctenular Keratoconjunctivitis, was primarily linked to Mycobacterium tuberculosis. However, with the improvement of living standards and also in TB-free regions, PKC has been associated with other infections agents as well, including Staphylococcus proteins, chlamydia, Moraxella axonfil bacillus, coccidioides, Candida, herpes simplex virus, and parasitic infections like that with Hymenopilus nana. Now, over here, first of all, sensitization or prolonged exposure to the organism is important. This prolonged exposure leads to sensitization, and on repeated exposure, there will be activation of the T helper cells, leading to delayed type of hypersensitivity reaction. So let's discuss this pathogenesis of phlyctenular keratoconjunctivitis in detail. Immunologically, the pathogenesis of PKC is presumed to be a cell-mediated type hypersensitivity reaction to the microbial antigens that we just discussed. The histological findings in a phlycten biopsy basically includes predominantly the monocyte-derived cells. These could be the macrophages, these could be Langerhans cells, lymphocytes, and it's very similar to the tuberculin skill reaction. Also, if the phlycten undergoes necrosis, you may also find the neutrophils over here. What is important to note over here is that you will not find any microorganism within the phlycten biopsies, and this supports that it is purely an immune mediated mechanism. So although the microorganisms are sensitizing the conjunctiva leading to activation of immune response, you basically do not find the microorganisms actively residing within these phlyctens. Okay, so that was the pathogenesis of phlyctenular keratoconjunctivitis. Let's talk about the predisposing factors. The peak age of occurrence is in mid-teens and it's pretty rare before 3 years of age. The incidence is higher in females and it is more common in spring and summer. Undernourishment, overcrowded regions, unhygienic liver conditions basically predispose to phlyctenular keratoconjunctivitis. Now, as I told you that before the 19th century, tuberculosis was the main reason behind PKC. So first we'll talk about the tuberculosis associated PKC. It is still a major factor, a major causative agent in overcrowded areas. So over here in the tuberculoprotein induced PKC, that is the phlyctenular keratoconjunctivitis, the host basically becomes sensitized from the bacteremia which is associated with a past pulmonary infection of TB, right? So an attack of PKC is then precipitated when the tuberculous antigens are presented to the eye either either from an endogenous source, that is maybe via the bloodstream, or exogenously through the environment. So exogenously they might get inoculated into the conjunctival sac. Now that would trigger the sensitization and hypersensitivity reaction, leading to tuberculosis associated phlyctenular keratoconjunctivitis. For example, in this case, the first picture here shows the anterior segment photograph showing multiple phlyctens which are standing out in the background of conjunctival hyperemia. So you see these blood vessels here. So there's diffuse hyperemia and you see multiple phlyctens in this case. And then when they were stained with fluorescent dye, you can see the nodules also taking the fluorescent dye staining. Here you can see positive tuberculin sensitivity test, and the chest X-ray, as you can see here, is showing on the right side mid-zone consolidation, that is marked by this blue arrow here. And also what you can see here is this hilar lymphadenopathy marked by the red arrow. And here with the black arrow, what you see is basically blunting of the costophrenic angles indicative of pleural effusion. That means this patient basically had pulmonary tuberculosis, and this pulmonary tuberculosis, or the bacteria which was present in the lung, it got disseminated into the blood, and through blood it reached the eye and that sensitized the eye. And later on, because of this constant exposure to Mycobacterium tuberculosis, maybe endogenously in this case, the hypersensitivity was triggered, and that led to development of these phlyctens. Now the last picture is basically, you can see the lesions have been resolved without any scarring post 1 week of topical steroid therapy. Now this condition basically resolves very well to steroid. Now let's talk about the Staphylococcus associated Phlyctenular Keratoconjunctivitis. Now in patients with tuberculosis, the sensitization basically occurred because of the bacteremia from an early infection in the lungs. However, here in Staphylococcus associated Phlyctenular Keratoconjunctivitis, the sensitization will occur due to the chronic colonization of the eyelids. We know that Staph aureus basically likes to colonize the nasal mucosa and also the eyelids. So this chronic blepharitis can lead to continuous exposure of the cornea and the conjunctiva to Staph aureus antigens, and this can induce the development of Phlyctenular keratoconjunctivitis. Moreover, the staphylococcus have these exotoxins which facilitate the antigen penetration by disrupting the corneal epithelium. So that is something that you must remember. Alright, let's talk about the clinical picture of both these conditions. So in this we'll be discussing the signs and the symptoms. So you can find these nodular structures in the conjunctiva or in the cornea. So if you find them in the conjunctiva, it is known as conjunctival phlyctenules, and these basically result in mild symptom. For example, the patient can have foreign body sensation or itching. However, if you have corneal phlyctenules or the patient has corneal phlyctenules, in that case, the symptoms are going to be severe. There will be significant photophobia, pain, tearing, and also blepharospasm. The afflicted patient makes every effort to shield their eyes from the light. Also, what you need to know is that the Staphylococcus phlyctenules basically may cause less photophobia than the tuberculous ones. Alright, so since we are talking about this Phlyctenular keratoconjunctivitis, so this was the paper that tried describing the various morphologies in which you can see this Phlyctenular keratoconjunctivitis, specifically in the cornea. So you can see here is an undifferentiated limbal scar or a limbal lesion. Here you have a wedge-shaped lesion with the base basically towards the limbus. Here again you have a lesion which is triangular shape with an extension towards the center. This is also known as the characteristic wedge-shaped fascicular lesion or fascicular scar. Here you can see a faint solitary corneal opacity without any corresponding limbal lesion. Here you have this generalized nebular corneal opacity that is basically indicative of the advanced disease. So I'll talk about how phlyctenular keratoconjunctivitis basically evolves. So you should know that it basically starts in the limbal region and then it progresses towards the center. So if you find lesion in the center, it means that you have a migrating disease. Alright, again you can have a lesion like this with the corresponding vascularization. Alright, so there are various morphologies in which this phlyctenular keratoconjunctivitis can present. Here you can see the lesion limited to the conjunctiva. So this is phlyctenular conjunctivitis. Here you can see the phlyctenule present in the cornea with a leash of vessels here. right? So all these leash of vessels or vascularization is pretty common with whitish elevated lesion in this phlyctenular keratoconjunctivitis. All right, so let's describe the conjunctival phlyctenules first. So these are basically common near the limbus, but they can appear anywhere on the bulbar conjunctiva. Usually, you're going to see a pink, fleshy nodule about 2 to 3 millimeters. Later, they become yellowish to grayish in color. They can ulcerate and they also reepithelize pretty quickly in 1 to 2 weeks, and they do not leave any conjunctival scarring, right? So, no conjunctival scarring after healing. That is something which is very important. Now, the patient with a conjunctival phlyctenule may have a corneal phlyctenule or may have had a corneal phlyctenule with the last attack, or may actually have a corneal phlyctenule on the next attack. So it's not just that you will see them in isolation. So one more feature of the conjunctival phlyctenule is that they will undergo necrosis and they can actually look like micro abscesses. So it'll feel as if there are multiple micro abscesses. For example, here you can see this whitish lesion. So it looks like a micro abscess. Moreover, you can see this reddish appearance around it. So this is localized conjunctival hyperemia and telangiectatic vessels around it. This is the same slit lamp image of the similar conjunctival phlyctenule. Then we have the corneal phlyctenules. These also basically, they usually start at the limbus as a white nodule and there will be intense amount of conjunctival injection. Then they will undergo necrosis and they might actually form ulcers at the limbus. Now this is pretty different from the marginal ulcers, let me tell you. So we'll talk about that in the differentials. Healing results in a triangular anterior stromal scarring. So the base of that scar is going to be present at the limbus. And these will be associated with superficial neovascularization, pannus, and typically it will be present in the inferior region and will be irregular in shape. Now, if the phlyctenules are basically recurrent in nature, they will actually start undergoing necrosis centrally and also they will spread centrally towards the cornea, towards the center of the cornea and appear to wander across the cornea, and that is known as a wandering phlyctenule or a migrating phlyctenular keratoconjunctivitis. Okay, so let's see some of these lesions. Over here you can see this lesion. So this lesion usually starts on the either side of the limbus as a white mound bordered by the on the conjunctival side by the fan of dilated vessels over here, right? So that is important. These clues are very helpful to the clinician in differentiating these ulcers from the catarrhal type of ulcers. So catarrhal ulcers basically are the ulcers which have a mucus appearance to them, and I'm talking about the marginal keratitis here. So how do you differentiate between the ulcers related to phlyctenular keratitis from the catarrhal or the marginal keratitis? So you should know that in the marginal keratitis, you are going to find an intervening clear area between the limbus and the ulcer. Okay, however, here there's not going to be any clear intervening zone between the cornea, between the limbus and the ulcer. Moreover, these phlyctenular ulcers are going to be perpendicular rather than being in parallel orientation to the lesion with reference to the limbus. Okay, so what I mean to say is, for example, let me try to draw and tell you. So when I talk about phlycten, the phlyctenular keratitis, they are usually going to be perpendicular, whereas the marginal keratitis is usually going to be circumferential or parallel to the limbus, and there's going to be an intervening zone between the keratitis and the limbus. So that is one differential point. Also these lesions can ultimately undergo necrosis and finally lead to ulceration, as you can see over here. Now, they start healing, but sometimes, as you can see, as they heal, they can recur and then they start spreading towards the center. And as you can see over here, this ulcer seems to have traveled towards the center of the cornea as a progressing gray necrotic superficial, I can call it a fascicular wandering ulcer surrounded by a wide infiltrate. So, see the ulcer, and here you have this infiltrate. Okay, and moreover, you can also see some of the superficial vascularization over here, right? This is known as a wandering type of ulcer with superficial vascularized scar. Again, here what you find is an elevated corneal phlyctenule with surrounding neovascularization and scarring. And this is demonstrating a typical sort of triangular shape. So the triangular, fascicular or wedge shape is something which is used in literature to describe the Phlyctenular Keratoconjunctivitis. So also if you stain it, this part will take basically the stain. I'm talking about the fluorescent staining, and that indicates that this is basically the progressive lesion of the ulcer, right? Okay, so when you do a biopsy, what are you going to find over here? You are basically going to find macrophages, lymphocytes, plasma cells, and polymorphonuclear leukocytes, which are nothing but your neutrophils. So you're not going to find the organism here. So what if you have to remember something? Remember that these are just immune reactions. You're going to find all these inflammatory cells. Usually you can have a corneal or you can have a conjunctival phlyctenule. Usually they start from the limbus, and if you see something like this towards the center of the cornea, and it seemed to have some sort of connection from the limbus, it basically gives you a clue that you're dealing with phlyctenular keratoconjunctivitis, because it starts from the limbus and goes towards the center. Towards the center, you're going to have the advancing edge of the keratitis, and it will be associated with this immense sort of neovascularization or inferior panels. Moreover, about scarring, if you see, these will actually heal very well with your steroid drops, and the scar also may take any form from an undifferentiated limbal scar to a characteristic wedge shaped fascicular scar that you see over here. Okay, this is another case where basically this child actually had this recurrent sort of unilateral corneal phlyctenular keratitis, and this was basically because the child actually was suffering from Hymenolipis nana, which is a parasitic infection in the intestine. The stool examination basically helped in diagnosis, and after treatment, it completely got resolved. Now, what are the less common manifestations apart from the corneal and conjunctival phlyctenules? You can also have miliary phlyctenulosis. Here, you're going to find multiple small phlyctenules diffusely over the cornea. Okay. Now, usually phlyctenules can resolve very well. However, in rare cases, there might also be corneal perforation. So, with this, let's discuss about the complications of phlyctenular keratoconjunctivitis. So, you can have corneal ulceration, you can have pannus formation, that is neovascularization. You can have fibrosis, scarring, and because of the scar, there might be changes in the refraction of the eye, and that can lead to astigmatism, reduced vision, and amblyopia. If there's an epithelial defect because of the ulceration, it can lead to secondary infection as well, and that can cause corneal melting and perforation, which are, of course, rare manifestations or rare complications. Now, before we jump into the differential diagnosis of phlyctenular keratoconjunctivitis, let's review some of the clinical manifestations. So, you might have microabscess formation, and this happens mainly in the conjunctival phlyctenules. Usually, they will be well demarcated. There's going to be focal hyperemia or injection of conjunctiva. The corneal lesion will have some sort of connection to the limbus. The lesions can progress, or the progression of the ulcer from the periphery to the center of the cornea. So that's the direction from the limbus to the center. You are not going to find any keratic precipitates or anterior chamber reaction. So what I mean to say is the inflammation or the immunological reaction is going to be limited to the cornea and conjunctiva. When we talk about the conjunctival involvement, you are going to find mild to moderate symptoms which will last for 1 to 2 weeks. When we talk about the corneal involvement, it could be recurrent and you will have more severe symptoms, photophobia, blepharospasms, so on and so forth. So when we talk about the differential diagnosis of phlyctenular keratoconjunctivitis, we shall be discussing it in various stages. Differentials at the nodular stage, differentials at the ulcerative stage, and differentials at the healing stage. The first differential would be at the nodular stage, and that would be the Salzmann corneal nodules. So this is basically a degenerative condition. It's a non-inflammatory, slowly progressive degenerative conditions of the cornea. And here what you're going to find is, so here what you're going to find is these nodules which are slightly bluish in color, and they are basically nothing but their hyaline tissue which is located anterior to the Bowman's layer. However, phlyctins are inflammatory, they have lots of vascularization associated with them, and they can migrate across the cornea. So again, you can see the Salzmann nodules, I'm so sorry. They occur due to the chronic corneal irritation like dry eye or previous inflammation or keratitis. They can be located in the periphery or the mid-peripheral cornea. They are bluish white in color, elevated smooth nodules with minimal or almost absent vascularization. However, the phlyctenules basically is a hypersensitivity reaction commonly to the microbial antigen. The location is interpalpable in the limbal area and they can progress toward the center. They're going to be much smaller than the Salzmann nodules and they're inflammatory nodules with surrounding redness. They are prominent with a trailing neovascularization in progressive cases. So what I mean by trailing is, so if you have this is cornea and this is the phlyctenule. Here this is the advancing edge. So on the trailing end, you are going to find vascularization. Okay, so that was the first differential. Another thing which can resemble Phlyctenular keratoconjunctivitis is the presence of limbal papillae in VKC or vernal keratoconjunctivitis. However, it's pretty easy to differentiate. Phlyctenules are small inflammatory lesions. However, in case of vernal keratoconjunctivitis, you will find this condition to be bilateral. Moreover, you will find this gelatinous limbal lesion, and sometimes you can also find these Horner-Trantas dots, which are nothing but white limbal spots of degenerated eosinophils. So these are more specific to VKC and they're not seen in Phlyctenular keratoconjunctivitis. So phlyctenules, as I told you, they are going to be hypersensitivity reaction. However, the VKC is type 1 and type 4 hypersensitivity reaction. You're going to find Horner-Trantas dots and limbal VKC is more common in the superior part. You will have associated signs like cobblestone like papillae with gelatinous limbal thickening. You might have superficial vascularization. However, the vascularization in phlyctenules is more prominent and the symptom that you look out for is itching. So in VKC, the patient will have intense itching. Okay, moreover, you will have wandering phlyctenule in case of phlyctenulosis, whereas in VKC, you might have shield ulcer. All right. The third differential is an inflamed pinguecula or pingueculitis. Now, important thing to note here is that they are going to have this yellowish sort of appearance or tinge to them. They can be located at 3 o'clock to 9 o'clock, 3 o'clock or 9 o'clock position because those are the areas which are exposed to sunlight and UV radiation. They will not undergo any sort of ulceration or microabscess formation. Okay, so that is one important differential point. However, you can see vessels also here. So how to differentiate? Phlyctenules basically are hypersensitivity reactions. Pingueculitis is because of the UV exposure and chronic irritation. Location of phlyctenules mostly near the limbus. However, you can get them at other location as well. But pingueculitis is on the bulbar conjunctiva. Appearance wise, pingueculitis will be yellowish and these will be small whitish raised lesion with surrounding redness. Pingueculitis will have a more localized redness, right? About the corneal neovascularization, that is more common in phlyctenule, and here you have mostly the conjunctival hyperemia around the pinguecula without any corneal involvement. All right. The fourth differential diagnosis is that of nodular episcleritis. Now, the nodular episcleritis, you are going to see prominent you're basically going to see prominent episcleral vessels over here, and these nodular episcleritic lesions will not undergo any sort of ulceration. They are not going to migrate and they will not have any microabscess formation. Very rare. Okay, so that is something that helps you differentiate. Moreover, nodular episcleritis will have a longer course of duration. Usually, you are going to see these nodules of 2 to 3 weeks of duration. So that's important. So these are going to be associated with systemic autoimmune disorders. So patient will have either rheumatoid arthritis, SLE or inflammatory bowel disease. Usually you are going to see them on episclera. They will have a slightish pinkish hue to them. So an episcleral nodule will have a pinkish hue with overlying dilated blood vessels. So that is important. Also, what is important is that in nodular episcleritis, mild amount of tenderness and discomfort will be associated along with photophobia. Okay, whereas in case of conjunctival phlyctenules, the symptoms will be on the milder side. So that is one important differentiating point. So what are the differential diagnoses? We have Salzmann nodular degeneration, nodular episcleritis, inflamed pinguecula, and limbal papillae in VKC. Let's see the differentials in the ulcerative stage. So here, one differential is peripheral ulcerative keratitis, which can also be abbreviated as PUK. So here you will see this crescent or banana shaped ulcers at the limbus, and these ulcers are very dangerous. They can progress really fast, and they are associated with collagen vascular disorders like rheumatoid arthritis, SLE, and uh, polyarthritis nodosa. Okay, so they are located in the periphery. They have a characteristic crescent shaped stromal thinning, and they can undergo perforation really fast. Okay, so that is one differential. Then you can have marginal ulcers or catarrhal ulcers. I told you here you are going to see clear space between the lesion and the limbus. However, in phlyctenular keratoconjunctivitis, they are going to start right at the limbus. Moreover, look at this ulcer of marginal keratitis. They basically, their orientation is parallel to the corneal circumference. So these are again some of the lesions of marginal keratitis. You still see some amount of empty space here. So these are basically located within the 2 mm of the limbus, sparing the limbal area itself. However, the phlyctenular keratitis will start at the limbus and then progress toward the center. They will have a crescent shape epithelial defect with overhanging edge, no central involvement. And these ones, the phlyctenular, however, are a localized small ulcer with a vascularized trailing edge. So you don't see much amount of vascularization here, but in phlyctenulosis, you will see greater amount of neovascularization. So that is important point. Similarly, microbial ulcers also could be on the differentials. However, here you are going to see intense anterior chamber reaction, intense hyperemia, and of course, there will be some history related to trauma, or patient would give history of coming in contact with vegetative matter, so on and so forth. Moreover, there will be greater discomfort and severe pain in these patients. What about in the healing stage? Now, usually in phlyctenulosis, you are going to see those fascicular scars, but one differential is that of trachoma. But you can clearly differentiate it from the phlyctenulosis by the presence of these Herber pits and this fibrosis that you see in the palpebral conjunctiva. And usually the pannus associated with trachoma is a superior pannus compared to PKC pannus, which is irregular and inferior. Luitic keratitis or syphilitic keratitis basically also can give you a scar like this, but this scar usually involves deeper layers of the cornea. This is called interstitial keratitis. Moreover, you are going to find these straight stromal vessels or ghost vessels also sometimes, and there will be some signs of past iritis like synecdoche and so on, so forth. In case of phlyctenular keratoconjunctivitis, you don't see anterior chamber reactions, so you won't find any iritis as well. Another close differential is rosacea keratitis. So here you are going to see diffuse inferior involvement with superficial vascularization and punctate epithelial erosion. So very tiny epithelial erosions is what you are going to find in case of this rosacea keratitis. Moreover, the patient will have these dilated vessels on the skin. So this is known as facial telangiectasias and erythema. So if the patient has this sign, it is very clear that the patient is suffering from rosacea keratitis. Now let us see how do we diagnose the condition. So basically we will be carrying out various infectious workup based on the suspicion. So if we are suspecting tuberculosis, specifically in a patient with history of travel to endemic areas, unexplained pulmonary symptoms, or with close household contacts with TB. In these patients, the tests to be considered are the Montoux test, chest X-ray, interferon gamma release assay, and sputum testing. If we are suspecting chlamydia trachomatis, this is considered in young adults with sexual risk factors. Suspicious examination findings like the presence of chronic conjunctivitis with follicular response. In these patients, you can carry out tests like immunofluorescent antibody testing or PCR of the conjunctival swabs, and they will provide you quick and accurate screening for chlamydia. There has been a 40% positivity rate for chlamydia in PKC patient. Similarly, if you are suspecting other bacterial or viral causes, you can carry out the related tests with the corneal scrapings or cultures, and even stool examination in case of suspicious parasitic infections. Clinical clues to differentiate PKC from other ulcers is that you should know that PKCs basically respond well to corticosteroids. However, whenever we are talking about microbial keratitis, infectious ulcers, these are going to worsen with steroids and they require antimicrobials. Let's talk about treatment. The main aim of treatment is number one, the acute management of inflammation, and number two is preventing the recurrences. So first we'll talk about the short-term treatment goal, which is acute management of inflammation. Here, topical corticosteroids could be used. You can use prednisolone acetate 1%. Initial dose would be 4 to 6 times per day, and then tapering will begin within first week based on the clinical response. Now, the TB related phlyctenules basically respond poorly and have a prolonged course. Now, when we talk about topical corticosteroid, you should know that there's a risk of increased intraocular pressure. So, that has to be kept in mind. In cases with multiple recurrences and those which might become dependent to steroid, topical cyclosporin A is also an effective treatment option. Okay, so the same principles that we applied in treating VKC with steroid could be applied with PKC as well, that is a Phlyctenular Keratoconjunctivitis. If not prednisolone, you can also use low potency steroids like lotipred or FML. Alright. Apart from that, specifically in cases where there's a corneal epithelial defect, that means you carry out your fluorescence staining and you find that the keratitis basically has taken up a stain at particular location, you know that there's a corneal epithelial defect present. Now that corneal epithelial defect will make the cornea susceptible to a secondary infection. And more so, since you are giving steroids, it's important that you start topical antibiotics in these cases and wait for the corneal epithelial defect to heal before you start these steroids. For conjunctival lesions, you can start steroids immediately. Apart from that, supportive treatments like cycloplegics for pain relief and photophobia and dark sunglasses could be prescribed, and they basically are helpful for light sensitivity. Coming to the long term treatment goals, and here the aim is to prevent recurrences. So we try here to eliminate the antigenic load to prevent recurrence. So here it's important that you identify and treat the underlying cause. So if you are dealing with PKC associated with tuberculoprotein induced one, so here what we'll do is we will prescribe the patient anti-tubercular treatment for primary TB infection. Also, screening and treating household contact with positive tuberculin test is also done. In PKC associated with Staphylococcus aureus, eyelid hygiene, that is lid scrubs to remove bacterial colonies, is important. Also, topical antibiotic ointments like erythromycin or 1.5% azithromycin could be prescribed to reduce the lid margin colonization. In refractory cases or recurrent cases, even oral tetracyclines could be started. And here I'm talking about doxycycline 250 milligrams 3 times per day. And you have to continue this until 6 weeks after complete resolution. And then you gradually taper by 250 milligrams every 2 to 4 weeks to once daily. Contraindication is these are contraindicated in children less than 8 years because there's a risk of permanent tooth discoloration, and also in pregnant and nursing women. Alternative to doxycycline is erythromycin. Now, complicated cases, yes, PKC can get complicated, specifically corneal perforation can arise, and in those cases, you have to treat the patient for peripheral perforations using corneal glue or amniotic membrane graft, corneal patch graft, so on and so forth. So, that comes under the surgical treatment of PKC cases in rare instances. So that was regarding the Phlyctenular Keratoconjunctivitis. I hope you enjoyed this video, and if you did, I think you will also like the video on vernal keratoconjunctivitis. That's all for today. Thank you for watching. Have a nice day.